Okay, so growing bones widen as they lengthen through appositional growth. This is another growth that can occur throughout life because of that periosteum. Bones thicken in response also to increased stress from muscle activity or added weight. So this is one of the best benefits of exercise on your aging skeleton. Osteoblasts beneath our periosteum are going to be able to secrete bone matrix on the outside of the bone. Osteoclasts remove bone on the inside so that the medullary cavity grows with the bone. And usually we have more building up than breaking down. So this leads to bigger, thicker, stronger bones that aren't too heavy. So all throughout use, we are developing and growing these bones, and then like before growth and remodeling happens, you can see, this would be the kind of shape of our bone, and then as we're growing interstitially here, we start pushing up the epiphysis there, pushing out because we grow from the inside out, and then we get thicker as the periosteum lays stuff down on the outside. Bone and what this is showing you is how our osteoclasts then would be working to resorb the bone here and resorb the bone here so that we are shaping appropriately on the outside and the inside as that bone grows up. As far as hormonal regulation of bone growth goes, growth hormone is the most important. Growth hormone is abbreviated GH. This is the most important for determining bone growth. So when growth hormone is high throughout childhood and adolescence, our bones are growing. When growth hormones start dropping off at the end of adolescence, we'll start fusing those epiphyseal plates. Thyroid hormone is a hormone that increases the activity of other hormones that it's working with. So this also helps with the bone growth in childhood and adolescence by acting as a synergist with growth hormone. So thyroid hormones are abbreviated TH, and these also increase bone growth. And I'm just going to tell you that they work synergistically, or it's a synergist with growth hormone. So that when the two hormones are present in the system together, we get more bang for our buck and we do more growing. Okay, testosterone for males and estrogens for females are going to go up at puberty. And so that is going to help with increasing protein deposition in our bones. And then it's going to, like toward the end of toward the end of adolescence, it's actually going to help induce the epiphyseal plate closure, both of those hormones. So our sex hormones, which is testosterone in males and estrogen in females, these will say they're both protein anabolic. So you may have heard, that bodybuilders do anabolic steroids. Anabolism is building up. Both of these hormones are protein anabolic. Testosterone is better, stronger, and that's why people do synthetic androgens. Estrogens, though, is also protective for bone. That's why when females undergo menopause and estrogen drops off, all of a sudden you start seeing osteoporosis. So estrogens and testosterones for both for males and females, we could say these are both protein anabolic. So they help with bone development. And they induce epiphyseal plate closure at the end of adolescence. Just something to kind of be aware of. Okay, so bone remodeling is going to occur all throughout the rest of our life, and there are two parts: bone resorption. This is the process of breaking down bone matrix. What cells do this? Osteoclasts. Yeah, osteoclasts. So osteoclasts are our bone resorbing cells. Bone deposition or bone deposit is when we lay down new bone matrix. So bone deposition is laying down bone matrix or osteoid. Bone matrix is osteoid. What cells let it down at first? Osteoblasts. What cells maintain it? Osteocytes. So when we're just laying it down, we could think about that as being osteoblasts, and then we could say that it's maintained by osteocytes. So remodeling occurs continuously, but it's regulated genetically and then by two control loops. We can have hormonal negative feedback control mechanisms when blood calcium goes high or low, or we can also remodel our bones in response to mechanical stress. So remodeling all throughout the rest of your life is this process of bone deposition and bone resorption, depending on what's going on with your blood, as far as levels of calcium goes, or depending on how much you use it. So all the time in your body, if you don't use it, you lose it. Well, this is also true with bone. So the more you exercise and things in your even starting now, in your 30s, when you begin to become old, then you can stimulate more bone deposition by mechanically stressing your bones so that they become stronger because you're using them. So, any questions so far? All right, our hormonal controls are going to give us two negative feedback loops. So this is how we can control remodeling, and so because our bones are our primary storage site for calcium, that's going to be an area that we can access when our blood calcium goes low. So it's kind of weird when we start thinking about all the hormones that do this. I'll go through this in a minute. I'm going to go through the other way first, but why I'm telling you this is because often in life as adults, we are low in blood calcium. So we have to get calcium back out. We can do that by stimulating bone resorption. The hormone that does that is this hormone called parathyroid hormone. It's the hypercalcemic hormone because it increases your calcium. The stimulus for its release is hypocalcemia. So everything kind of gets weird when we start looking at these words and trying to think about which way the negative feedback loops go. Because all I have to do is just like throw in a hyper or hypocalcemic in a weird spot in a question, and now all of a sudden you can't remember what this hormone is doing. So there's a poem, and it goes, calcitonin puts the bone in, parathyroid hormone does the opposite. So that's, so calcitonin puts the bone in. Parathyroid hormone does the opposite. So, then, what the heck, before we go there then, to parathyroid hormone doing the opposite, what the heck's calcitonin? And how does it put the bone in? Calcitonin is this hormone that's high during adolescence, and it's high in pregnant females when we really need to be making bones. And calcitonin is coming from your thyroid gland, and it's causing your body to take calcium out of the blood and deposit it, put it in. So if we're thinking about stimulus, when would I want to put bone in? High or low calcium? When I'm high. Or when I'm making a baby, because yeah, so what happens when you're making a baby is you'll pull all the calcium out of the mother's bones to make the fetal skeleton. It's so important. But calcitonin is going to be able to pull calcium out of the blood and stimulate bone deposition. So, and it's not the most important in normal everyday functioning of adults. But it does happen, and it's how we get our poem. So we're going to do both loops. When blood calcium is high and when it's low. So when blood calcium is high, the sensor, we always have to have a sensor, are these cells called C cells in the thyroid. And they're going to respond by releasing calcitonin. Calcitonin stimulates our effectors. So is calcitonin, so let's think about every part of a negative feedback loop. Our effectors are out here, and they're going to be able to bring about some change that brings us back to homeostasis. What do I need to do to bring us back to homeostasis? I need to lower my blood calcium, right? So what are some cells in bone that can take this calcium and do something? Osteocytes can take this calcium and maintain bone matrix. So they can lay down more osteoid. On the outside, in my periosteum, or on the inside in my endosteum, I could have osteoblasts that can also respond to that. Really, kids have this high. Kids have calcitonin in high levels. Pregnant females have calcitonin high in high levels. So their osteoblasts can also respond to that calcitonin and lay down or do bone deposition. So we'll say deposit bone or deposit osteoid. So this is an effector. What do I think the control center is? Everything I have in my pathway is right here. My control center are these guys. They are also the receptor. So this brings up an important point that not always are our control center and our receptor different. This time they're the same. Because as long as these cells are sensing this change, they'll continue releasing calcitonin. And you might say, well, why isn't calcitonin the control center? Calcitonin's not thinking about anything. These cells are thinking about how much calcium's out there. They're integrating that and they're responding by sending out an efferent message. So calcitonin is the message that's impacting our effectors. And now my osteocytes and osteoblasts can take up that calcium and make osteoid. I've got two other effectors. In my kidney, I can stimulate excretion. So I can pull out any extra excess calcium and concentrate it in my urine.
Yes, but then, yes, I know somebody that has that going on.
And then, at my small intestine, it's not super hard to inhibit calcium absorption. It's actually hard to absorb it. But if there's any calcium floating around in your small intestine, you're not going to absorb it when calcitonin is high.
What was that?
Small intestine.
Thank you. So when your kidneys are pulling it out, or at least taking it out of your bones
They're taking it out of the blood. What we have is increased calcium in the blood.
So do your bones become brittle that way?
Because if I've got an increase in calcium, I'm laying down bone.
But does it, well...
So this is how I come back to homeostasis, right? The stimulus was too much calcium. These take that calcium out and put it in bone. My kidneys pull it out of my blood and excrete it from my body in urine. So now I've lowered my calcium. Okay? So this is most important in kids and pregnant females. Not horribly important in all of the rest of us normal adults. Because it's very rare that we're high in calcium and our bones have grown. What is more important is the opposite. Because hypocalcemia happens a lot. So as adults, it can be pretty frequent that we're low in calcium. And since calcium is important for signaling of all sorts, neuron signaling, our muscle contraction, then we need to make sure we have homeostatic levels of calcium. So this feedback loop is what's more physiologically significant for us, but we can't get the poem without calcitonin. So now, what happens more often as an adult is that we'll have a drop in blood calcium. So I would be hypocalcemic if I have a drop in blood calcium. This is sensed by cells in our parathyroid glands called chief cells. So in our parathyroid glands, and they're going to respond by releasing parathyroid hormone. Parathyroid hormone has the same targets as calcitonin, but the opposite effect. So, who can I stimulate at bone to get calcium out? Osteoclast. So I increase osteoclast activity. What we could say is that I stimulate resorption. So this is going to release calcium to the blood and help to combat that. Oh, here's a great, well, hold on. At the kidney, if I had anything that was becoming urine and there was calcium in it, so here's my blood over here, and here's what's becoming urine over here. If there's any calcium in what's becoming urine, at my kidney, I could stimulate reabsorption with parathyroid hormone. So it's reabsorption of calcium. And you say, why is it reabsorption? Well, it was in my blood, I filtered it out, but now parathyroid hormone's present, I gotta bring it back. So I'm reabsorbing it. And then this could be a good, like, bonus type points. How is the integument related to blood calcium homeostasis? How is the integument related to blood calcium homeostasis? Well, in the integument, we had the precursor to vitamin D3 that got activated when UV radiation hit our skin. Active vitamin D3 goes to the liver and becomes calcidiol. Calcidiol goes to the kidneys and becomes calcitriol. Calcitriol is a synergist with parathyroid hormone, specifically at the small intestine. When we have the two hormones present, we'll increase calcium transporters and we'll increase calcium absorption. So parathyroid hormone in the small intestine is going to increase calcium absorption, and specifically, this is best at the small intestine when we're working synergistically with calcitriol. I am not going to test everybody. Like, it would not be a 5-point essay question to describe the integument's role in blood calcium homeostasis. It could be a 5-point essay question to describe blood calcium homeostasis, and then for extra credit, describe how the integument helps. Okay? Make sense? Questions?